Hey, Srujan.
Sir, good morning.
Morning.
Looks like you're on the beach in Kerala.
Yes, giving you the Kerala vibes. Hi, Aditya.
Hello, Dr.
Yeah,
Nayak,
good
how
to
are
see
you?
you. Yeah,
Yeah, good
pretty
to see you
well.
too. Yeah, I'm doing well, thank you.
Yeah. Good
You're
morning,
looking
Dr.
great.
Subodh.
Good morning, sir, and welcome.
Yeah, thank you so much. Yeah, it's always pleasure to see you.
Same here, sir.
Yeah.
Morning, sir. Morning, sir.
Good morning, Srujan Kal. How are you?
Chal raha hai, sir. Shanu, can you just check your audio, please? We're presenting soon. Shantanu, can you hear me?
Yeah, I can hear you. Can you hear me?
Yeah, okay.
Yeah.
Most of your face is not seen in the video. Adjust that, please. Thank you.
Hey, Joseph.
Hey, sir. Good morning.
Morning.
Two minutes left.
I think we are all set up, sir. I don't see Dr. Tiwari on the... Tiwari, sir, is not joined yet, I think.
Srujan, it is clear that after the presentation, you have to moderate the session, involve the panelists. So don't ask questions to the presenter, right?
Yes, sir.
Yes. Yeah. You have to moderate, take the questions, involve the panelists. So it is the expert advice which matters.
Yes, sir.
So So 1 minute left.
Shall we start, sir?
Yeah, I think we can.
Dr. Tiwari, I think we've not seen.
We're going to start. So very good morning to one and all, and welcome to this TAC round of ISTAC. So it's a great pleasure to welcome Professor Shukriya Nayak, the Professor of Surgery at Believers Church Medical College, Tiruvalla, Kerala. Earlier, he was a professor and head of Department of Trauma Surgery at CMC Vellore. I think Dr. Sandeep Tiwari has not joined. We have with us another very eminent panelist, Dr. Aditya Benjamin. He's the Director of Trauma and Acute Care Surgery Unit at Liverpool Hospital, SW, Australia. Welcome, Dr. Aditya. We have with us the moderator of today's session, Dr. Sujan Sharma. He's the Associate Professor, Department of Trauma Surgery, CMC Vellore. And the presenter will be Dr. Shantanu Nayak. He's a Senior Resident. So over to Dr. Sujan Sharma, please.
Thank you, sir. First of all, thank you to ISTAC for involving Christian Medical College Vellore in this eminent discussion. I won't take too much of your time and move straight into the topic. This concept of damage control surgery is something that all of us who work in trauma are very, very well aware of. In India, where ISTAC is based, there is such a large unmet surgical need that those of us who work in trauma we cannot afford not to look at non-traumatic surgical emergencies. I, in fact, would posit that with our learning from trauma and our training in trauma surgery, we are best positioned to treat these patients. Over the next 20 minutes, we hope to have a shared learning experience with you all, where Shantanu, our senior resident, will try to apply or show you how we have applied damage control principles in acute care surgery. Over to you, Shantanu. Before you start, just a reminder, sir has already mentioned this. We will take questions at the end. Please put them in the chat box. And after that, we will ask the panelists for comments and their expert advice. Please keep your mics on mute. Over to you, Shantanu.
We'll start today's presentation. Yeah, Sujan has mentioned, we'll be looking at applications of TCS in non-trauma ACS. So at the onset, we'll just go through the objectives of this presentation today morning session to understand the application of principles of damage control surgery, non-traumatic abdominal emergencies, looking at the algorithm of damage control with regards to patient selection, preoperative resuscitation, concept of source control surgery, and the nuances of ICU management. I'll go through a couple of patients first. Patient 1. This is Mr. G, a 50-year-old man, was under evaluation for probable rectal malignancy elsewhere. He developed complaints of progressively worsening breathlessness for a duration of 5 days, requiring continuous NIV, after which he presented to our center for further management. An examination. He was found to be drowsy. He was pale. He was tachycardic, was tachypneic, requiring continuous NIV. Examination of the respiratory system revealed decreased air entry over the left side of the chest. And examination of the abdomen was unremarkable. Digital rectal examination revealed a hemicircumferential ulceroproliferative growth. Basic blood investigations revealed anemia with leukocytosis with left shift. The ABG done showed respiratory and metabolic alkalosis, along with a mildly increased lactate and base excess level. The INR was also mildly low. This is the CT. We had proceeded with the CT thorax abdomen pelvis study. This is the CT thorax section of the images, which shows a left diaphragmatic hernia with contents of transverse colon, just with evidence of perforation, the pneumothorax and the hemothorax. This is the abdomen sections of the study, which is normal. So the phase 0, the resuscitation of the patient in ED, was resuscitated with 1 liter of IV fluids, NS, 1 liter of normal saline. He received the first dose of broad spectrum IV antibiotics, injection meropenem. He was intubated in the ED in view of worsening respiratory distress and started on low dose single inotrope supports. He was taken up for surgery. A laparotomy was performed. The operative findings were those which colluded with those of the CT. There was a posterolateral left hemidiaphragm defect with contents of the transverse colon, which had perforated with evidence of fecal contamination. So phase 1 of damage DCS was performed, which entailed laparotomy, segmental transverse colon resection, a left pleural cavity lavage, and the left hemidiaphragm defect repair. This is a representative diagram of the surgery that was performed with segmental transverse colon resection and the repair of the diaphragm, left hemidiaphragm. So at this point, 90 minutes of operative time are over, at which point in time there was worsening inotrope requirements. Temperature had dropped to, core temperature dropped to 35 degrees Fahrenheit, and there's worsening ventilation and PF ratio, drop in PF ratio to 180. In view of this, the decision was taken to terminate the procedure and to shift the patient to ICU for further resuscitation. In the ICU, inotropes were tapered and discontinued. Injection teicoplanin was added for gram-positive cover, in addition to injection meropenem. Total parenteral nutrition was started. And over the duration of 24 hours with the resuscitation, clinical and lab parameters improved. He was then taken for phase 3 of the damage control surgery. A laparotomy was performed. This thoracoscopy was inserted through the left hemidiaphragm, which revealed findings of gross fecal contamination and adhesions, which the decision was made to convert to anterolateral thoracotomy. A decortication was done, followed by a diaphragm repair and a double barrel transverse colostomy. The bowel ends were healthy. Duration of surgery was 8 hours, blood loss 1.2 liters, received transfusion of 2 units of whole blood during surgery, and core temperature was 36. Following which, she was taken back to the ICU. PF ratio and lab parameters gradually improved with resuscitation by post-op day 1. Over the post-op period, inotropes were tapered discontinued. Cultures from the pleural fluid that grow multiple bacteria as well as Candida, in which injection fluconazole was added. Total parenteral nutrition was started and was shifted to enteral nutrition after extubation post-op day 3. Patient was shifted to the ward on post-op day 7 and discharged on post-op day 15. Moving on to patient 2, Mrs. A, a 53-year-old woman, presented with complaints of abdominal pain, vomiting, diarrhea for 1 day. No known comorbidities of hypertension. So she had presented to our ED. A surgical consult was sought around 6 to 8 hours after presentation. Presentation of vital parameters were within normal limits. She was found to be pale. After my examination, the diffuse tenderness and guarding present without any rigidity. Investigations had revealed anemia as well as gross leukocytosis with the left shift features. ABG done showed respiratory alkalosis and metabolic acidosis. So the CT cross-sectional imaging was planned for only, as I said, around 6 to 8 hours after the initial presentation, which shows an almost entire occlusion of the SMA, of the superior mesenteric artery. This is the arterial phase. And in the venous phase, we can see loss of mucosal enhancement of almost entire small bowel as well as the ascending colon. ABG done at this point revealed mixed acidosis along with elevated base excess and lactates level and elevated iron. Resuscitation with IV crystalloids was initiated. She received first dose of broad spectrum antibiotics, injection piperacillin tazobactam. She was then taken up for a laparotomy. The laparotomy findings were those of the gangrene of almost the entire length of the small bowel, starting from 40 centimeters from the DJ flexure, the ascending colon, and the proximal half of the transverse colon, all of which was resected in view of the gangrenous appearance. This is the staple lines of the jejunum and the transverse colon after resection of the gangrenous segment. So by this time, it was 90 minutes of operative time. There was worsening shock with inotrope requirements. Patient had a baseline low anemia of 5.8 grams per deciliter, requiring intraoperative transfusion. And also there was uncertain viability of the staple lens because we are not sure of the staple lens. At this point in time, decision was taken to terminate the surgery and shift the patient to ICU for further resuscitation. So with resuscitation measures in the ICU, there was a gradual decrease in the lactate level as well as the base excess level. After 24 hours, following ICU resuscitation, over the period of which inotropes were tapered and discontinued, she was continued on IV antibiotics. Total parenteral nutrition was initiated. Post-operative transfusion was continued. She was also started on therapeutic anticoagulation. Following these measures, the patient's physiology, both her clinical parameters and her lab parameters improved, and she was then taken up for phase 3 of the damage control surgery, where a side-to-side Hansen jejunocolic anastomosis, antiperistaltic anastomosis was performed. Post-operatively, again, she was shifted to the ICU on low-dose single inotropes and mechanical ventilation. Again, you can see that there is improvement in our laboratory parameters on the APG. So inotropes were tapered and discontinued. She was extubated on post-op day 1, and following she was shifted to the ward. And peritoneal fluid culture taken from the index surgery did not reveal growth of any bacteria. IV antibiotics were continued. TPN was shifted to enteral nutrition with a graded diet. She was started on therapeutic anticoagulation, injection Clexane in the immediate post-op period, followed by tablet apixaban when her oral intake improved. And she was also started on single antiplatelet medication. Discharged on post-op day 8 after diet counseling with plan for further procoagulant workup on an OPD basis. Okay, so we'll move on to the next part of our presentation. Why should we apply the principles of damage control surgery, which are classic teachings of the approach to trauma patients with hemorrhagic shock, to these cohort of patients who are non-trauma general surgery emergencies? Okay. So patients with the GSOs of sepsis are non-trauma acute care patients. They are stuck in this vicious. They're stuck in this vicious cycle. So intra-abdominal sepsis. This state is characterized by a state of excessive pro-inflammation, which causes a vicious cycle of septic shock, eventually culminating in multi-organ dysfunction and ultimately death. So the classical approach to these patients was to take the patient to the operative room and complete a surgery with anatomic reconstruction. But this was associated with worse patient outcomes. In view of this cycle of the septic shock cycle. So the shift in the management is to break this cycle, intervene before the patient deteriorates and progresses to such a stage, resuscitate with adequate volume with crystalloids, adequate antibiotic therapy, and then take a decision to proceed with the damage control algorithm, which would include a staged procedure with adequate resuscitation in the ICU so that normal physiology is restored before moving on to anatomic reconstruction. This is associated with better patient outcomes. So move on to the discussion regarding the damage control approach in non-trauma patients. The outline will be the outline we look at is which patient selection, which patients will benefit from this approach, the preoperative resuscitation that is required, the concept of source control surgery in these patients, followed by the nuances of the ICU management of these patients. Phase 0, which is the initial patient selection. So which patients will benefit from this procedure? There are four broad categories of patients who will benefit. Patients with deranged physiology, similar to our trauma patients, intra-abdominal sepsis, patients with intestinal ischemia, and patients with abdominal compartment syndrome. We look at each of these broad categories briefly. So first group of patients with deranged physiology, similar to our patients who present with trauma and hemorrhagic shock. They're characterized by acidosis, hypothermia, and coagulopathy, as well as hemodynamic instability. These patients, our non-trauma patients who present with these variables qualify for the damage control approach. Intra-abdominal sepsis, patients who the index surgery is insufficient to obtain complete source control, an inability to safely perform the GI tract reconstruction, and a significant uncertainty regarding intestinal viability are seen in our second patient. These patients with an intra-abdominal sepsis, diagnosis of intra-abdominal sepsis will qualify for this approach. The surgical strategies employed is the classical approach, on-demand relaparotomy, where there is symptoms or signs of deterioration post-operatively. Second surgery is warranted. Otherwise, patients who qualify for the damage control approach can have a planned relaparotomy approach where the skin and the fascia is temporarily closed. And once the patient is stable after 24 to 48 hours, a relook laparotomy is performed. The second approach is an open abdomen. We'll look at it in the next slide. Patient with open abdomen will require a temporary abdomen closure, who will also qualify for a planned re-exploration after 24 to 48 hours after normalization of the physiology. Intestinal ischemia is commonly associated with physiological derangement and findings of intra-abdominal sepsis. These patients will qualify for a damage control approach, as well as patients with intestinal ischemia who have significant uncertainty regarding the intestinal viability will warrant a second relook to assess the vascularity of the bowel. Abdominal compartment syndrome, due to physical inability to reapproximate the midline fascia, patients who develop symptoms of abdomen compartment syndrome, or there is a significant concern that post-operatively they will develop abdominal compartment syndrome. These two patients will also qualify for an open abdomen and a temporary abdomen closure approach, followed by a relook after 24 to 48 hours. Additional factors to look at is the patient's presentation, the comorbid conditions, the nature and severity of the disease and the pathology, the physiological factors at presentation, and the treatment factors. For example, our second patient, there was a delay in presentation. Our first patient presented 5 days following symptoms to the hospital. And our second patient, there was a delay in the initiation of required treatment. Also, the magnitude and quality of resuscitation and the surgery that is required also has to be taken into account while planning for a damage control approach. So the phase 0, we've now looked at which patients require a damage control in both trauma and acute care, the acute care patients. And the stark difference is in trauma surgery, it's a recognition of the injury pattern, while in acute care surgery, it's a recognition of the pathology and their physiology at presentation, which would necessitate a damage control approach. Okay. So the next stage of the damage control algorithm is the preoperative stabilization. In trauma patients, present with a hemorrhagic shock, non-trauma patients present with a septic shock, which is characterized by hypovolemia and a vasoplegic shock. The goal of treatment in trauma patients is hemorrhage control, while in a non-trauma group, the main focus of treatment is the control of the septic focus. Resuscitation in trauma patients is with minimal crystalloid resuscitation, adequate blood product resuscitation, and activation of massive transfusion protocol if required. While resuscitation in a non-trauma patient is with crystalloids, early vasopressor and inotrope supports if required, IV antibiotics, and there is a role of steroids to play in this group. So the principles of preoperative stabilization as per surviving sepsis campaign, adequate IV fluid resuscitation, crystalloid being the fluid of choice for resuscitation with a target mean arterial pressure of 65 millimeter mercury. Early administration of IV antimicrobials within 1 hour, use of norepinephrine as a first choice vasopressor, and attaining a specific anatomic diagnosis and proceeding with a source control intervention as soon as possible. Role of steroids. There is a role of steroids to play. There is a role of steroids to play in our acute care patients with administration of IV hydrocortisone only if adequate fluid resuscitation and vasopressor therapy are unable to restore hemodynamic stability. At the end of our preoperative stabilization, these are a few guideline endpoints which give us a clue that the patient's physiology is being restored. Central venous pressure, mean arterial pressure, urine output, central and mixed venous oxygen saturation. So at the end of phase 0 of the damage control, we have identified our patients who require a damage control approach, and we have looked at the differences between the resuscitation in our trauma and our non-trauma patients. Trauma surgery being hemorrhage control, and in acute care patients being resuscitation and administration of antibiotics. So moving on to the next phase of the damage control approach. This is dubbed source control energy because control of the infective focus is of paramount importance in this group of patients. The aims are to restore normal physiology, manage the source of infection at the expense of anatomic continuity, which can be restored at a later surgery. The 4 principles include drainage, debridement of the infective focus, decompression of the abdomen, restoration of anatomy and function at a later date. Few do's and don'ts for source control surgery. Do's include resection of the disease segments, address contamination, drainage of infected fluid, debridement of necrotic ischemic tissue, adequate lavage and placement of drains, restoration of the GI tract, placement of the enteral accesses, and maturation of ostomies can be done in the second stage and not to be done in the phase 1 stage of the damage control algorithm, because they are time-consuming procedures and the patient's physiology does not warrant the same. So phase 1, the difference between trauma and our non-trauma patients. In trauma patients, there is an emphasis on hemorrhage control, early hemorrhage control and control of contamination, while in our non-trauma patients, the main goal of surgery, as you've seen, is decontamination and control of the septic focus. Along with reassessment during surgery, similar variables and parameters are assessed intra-op as to make the decision as to how to proceed with the surgery, with the surgical process. ICU management of our patients is similar to trauma patients. The monitoring and the management is similar end goals. The difference being there is a focus on correction of septic shock and an establishment of a microbiological diagnosis with treatment of appropriate antibiotics. This is the difference in our non-trauma. This is the point that is different in our non-trauma patients. Initiation of early nutrition in order to manage sepsis, and monitoring of source control and for multi-organ failure is the process which occurs in the ICU. So once the patient's physiology is restored to normal, a decision has to be taken on when we can proceed to phase 3 of the damage control surgery, which includes restoration of normal anatomy. So during the phase 2 of the damage control algorithm, the recovery in the ICU, our treatment objectives, monitoring and management is similar, and the only stark difference being specific antibiotic therapy based on microbiological evidence. Phase 3 or definitive surgery is similar in both trauma surgery, acute care surgery, where there is a definitive anatomical restoration along with a formal abdominal wall closure. We've come to the end of this presentation. The take-home messages from today. It's important to remember that the key point is to treat septic shock, keeping in mind the lessons learned from the damage control approach in traumatic hemorrhage shock. Damage control principles do hold true in the non-traumatic settings. Restoration of physiology is the goal of the damage control approach, as opposed to a functional anatomical restoration. And it's important to know when to pause and when to take the patients back to the ICU for further resuscitation, so that the physiology is normalized, after which we can proceed with the next stage of surgery.
Thank you, Shantanu. There are a few questions that have come. The first question from Dr. Harshit, actually, I think Shantanu, you should answer this because it's about the case. He's asking if the second patient suffered a short bowel syndrome. If yes, how was it managed?
Okay. So she, after starting on graded oral diet, she had symptoms of diarrhea, frequency of episodes around 6 to 8 episodes, which have gradually decreased. She's under follow-up in our OPD. Even in the post-op period with measures of loperamide and diet counseling, her symptoms have improved, of diarrhea have improved. She has lost around 2 kgs over the past 1 month currently. No signs of overt nutritional deficiency as of now.
Thank you, Shantanu. Now over to the panelists. There's only one question so far. Maybe we can start with Dr. Sandeep. I believe he's joined. Dr. Venkatesh asks, if TPN in an early stage, please give insight. Essentially, he's asking when is it beneficial to start TPN because it could possibly cause new physiological changes. Dr. Sandeep, if you have joined, please enlighten us.
Yeah, good morning, everybody. And sorry for late joining. We should try as soon as possible to start the enteral nutrition as soon as the bowel physiology is maintained. If suppose the bowel physiology is not maintained and we have to maintain the nutrition, then parenteral nutrition should be started in a graded manner. That depends on the other things also, other physiological status also, like the status of the renal function and liver function. If it is okay, then we can start parenteral nutrition as soon as possible.
Thank you, sir. Because that question was already there while other people are coming up with questions. So would you mind telling us what your broad comments are about this topic while I still have you?
Yeah, the broad comments, if you say damage control was initially started in trauma patients as per literature. But if we see in early 90s or late 80s, we were already doing these kind of procedures of source control laparotomy, either local putting of a drain into the peritoneal cavity, who has come with perforation peritonitis and his general condition is very low, he's an elderly patient or he's having comorbidities or his ASA score is not good or Apache score is more than 7 or 11. So we were putting a drain, bilateral drain into the peritoneal cavity, and once the patient improves, then we were going for laparotomy. So obviously, the studies have shown that now this approach in acute care surgery is also gaining popularity, because in many patients, specifically those who have indicated by Shantanu, that the patients who are having comorbid conditions, who are in septic shock, who are having comorbidities, elderly patients, these type of patients, they do benefit from damage control surgery because this saves the time. And in early resuscitative phase, we can resuscitate the patient, then go for damage control surgery. As Dr. Shantanu has already emphasized, then we can go for ICU care and then definitive surgery.
Thank you, sir. That was very insightful. I'll posit the same question to Dr. Aditya now. What are your comments, Aditya? Can you just share with us what your thoughts about this approach are?
Yeah, thanks. Thank you, Srijan. I agree with all the points that were mentioned. Essentially, damage control surgery is now a cornerstone of the management of trauma patients. The results have been strongly positive. Essentially, we control the hemorrhage and let the patient's physiology improve while the patient is in the ICU, and take the patient back for a definitive management. And usually in trauma patients, within 48 hours, when we take the patient back, we can definitely close the abdomen. With the encouraging results of damage control surgery, which includes obviously keeping the abdomen open for a period of time, which might be 24 hours, 48 hours, depending on the case. And the newer technologies that have been there for management of open abdomen patients, the complications that were seen in the initial cases, they have been less and less. The biggest complication of having an open abdomen in these patients is for them to develop an intra-atmospheric fistula. The other problems that can happen is having the abdomen open and having the abdominal wall retract to such an extent that it is extremely difficult to close. And we'll have to resort to things like tongue component separation or a bridging mesh or something else. So keeping the abdomen open for more than a few days has those challenges. But increasingly, we are using negative pressure dressings, and that helps to mitigate these complications and also better control of the wound. In the acute surgical setting, we have also, encouraged by the results in trauma, we have started using, damage control principles. And yes, just like managing hemorrhagic shock, we are managing septic shock, and just like control of the bleeding, instead we are getting source control. The only there are clear indications, as you have pointed out. But in acute surgical patients, when we have the abdomen open or when we do damage control, generally the results may not be so quick. Patients may have the abdomen open for a longer period of time. I think one other thing I would like to mention is that the risk that we tend to take is encouraged by the positive effects of damage control surgery, encouraged by the acceptability of the use of open abdomens. We may tend to use it more when it is not indicated. That can happen because, after all, you have the opportunity to have another look. You have the opportunity to do definitive management later on. So there is a tendency to overuse damage control surgery. That should be avoided. In acute surgery, I think the biggest thing we should remember is that we should always keep an eye on whether the patient can be closed. And if the abdomen can be closed, it should be closed as soon as possible.
All right. Thank you, Aditya. Dr. Nayak, Professor Nayak, so over to you for your comments before we get back to the questions. Along with your comments, I'd like to bring in two questions, or rather 2 points of discussion that Aditya brought up. Should we always leave the abdomen open, or should we do what we did over here, is the temporary closure that was done for both patients between the 2 surgeries? And the second question is, do you also agree that there is a possibility of overusing this principle when it's not indicated, and how do we avoid that? So, Professor Naik, if you can give us your comments and address those questions.
Okay, thank you. I think as presented by Santanu, these 2 cases brings out the ideal cases for damage control principles applications in non-trauma group. There are others also included in this. I think that part we should be also aware about. I think going by the principles, what I see a paradigm shift in the approach of managing these patients. Being surgeons, most of the time we are inclined to do the anatomical corrections. But unfortunately, physiology takes a big toll in that. So therefore, it is a welcome approach that we are giving physiology more importance than anatomical corrections in the initial stages, as comes out very clearly in these cases, and all the panelists also agree. Then coming to the second and third questions which you asked, I think the second principle also comes quite handy in this. I would say that there is some similarity between the hernia surgical approach. Earlier, we used to pull them together and do a tension full repair, and then the principal paradigm shifted to tension free repair. So keeping that in mind, same principle should also be applied to the abdominal closures. So I do believe that there is more and more role for temporary abdominal closures in our setting. Very rarely, probably, we'll come across patients where the abdomen cannot be closed within a short time. So, in the initial stages, I do feel that we unnecessarily tend to close the abdomen when we know that there is abdominal hypertension or likely to lead to abdominal compartment syndrome. And many of our group of patients with perforation, peritonitis, intestinal obstructions are hypovolemic, hypoalbuminemic, nutritionally run down, and whatever suturing you do is not going to heal. So the tension sutures which was the practice when we are being trained, I think should be outdated and thrown out, because that causes more damage to the subsequent repair of the abdominal wall. So temporary closure is the choice, but how you do it probably will depend on the resources available. You don't have to always have the negative pressure therapy. It can be easily managed with small sterile gauze. So, the plastic sheets and offsides and some gauze pieces and suctions also can be used for a temporary closure. But one thing to remember is that this temporary closure is only for few days, not for weeks. We cannot keep this open for long time. Ideal is 3 to 4 days. One should be able to go in and close the abdomen. In the worst scenario, what I would think that if the linea alba, the rectus cannot be approximated, probably using a vicryl or observable mesh inside and close the skin on top, anticipating that these patients will develop ventral hernia and which can be dealt with at a later date. Thereby, you avoid all the complications of enteroatmospheric fistulas, which is a very common one when you keep the abdomen open. Even though with negative pressure, it is less, but still it is there. And when you use gauze pieces and pads and all for this, when you don't have the other sponge technique, enteroatmospheric fistula is a problem, and that is not going to go away so easily and very difficult to manage. So best is prevention. So I feel that temporary closure, even if that involves a vicryl mesh and then closing the skin, is well acceptable. Even if the vicryl mesh is not available, observable mesh is not available, still I think closing the abdomen skin closure within 1 week of the laparoscopy probably will be helpful in the long run. If you leave it beyond, then the complications are quite high. The third thing is about the nutritional aspect. I do agree that all these patients have got multisystemic, rundown, and usually the gut is not going to function within few days, 4 to 5 days. So the enteral feeding is going to be delayed or be inadequate. So keeping that in mind and overall benefit of the patients, starting TPN early enough in the first index presentation itself, I think goes a long way. And mind you, when the abdomen is swollen up, the intestines are also edematous. And imagine running down any food into that gut. Will that absorb? Probably not, because of the intestinal edema. So TPN probably helps to bridge that gap till the edema comes down and the intestine starts absorbing and contributes to the nutrition. So till that time, TPN is a must. I'm sure that is the money you spend as in TPN in the early stage will save a lot of money in the later part to avoid complications.
Thank you, sir. That was very, very succinct and quite insightful. Thank you for answering my questions as well. Shall we take the next question to Dr. Tiwari sir again? Dr. Pranab asks, what are the intraoperative cues that can guide a surgeon to switch to damage control surgery during non-trauma emergencies?
Yeah, it's a good question actually. Is the perioperatively, suppose the ASA score is going down, the patients is becoming hypotensive. If you see the physiology of the patient and the lactate is getting high in the peroperative or perioperative ABG, and more so if you see that there is a As Dr. Nayak has correctly said that the bowel condition is not good and it is very much edimated, or there is signs of gangrene, or there are signs of ischemia in the hollow viscus, then we can decide perioperatively that whether we have to go for, if suppose surgery is taking time, and then we can decide perioperatively also that we can restrict ourselves to damage control surgery. More so regarding the temporary abdominal closure, as Dr. Supriya has correctly said that we should, in most of the conditions, we are able to close the abdomen, but it has to be decided perioperatively. If it is a tension-free closure, then we can go for en masse closure of the abdomen. Otherwise, nowadays, negative pressure wound therapy is a very good option for temporary abdominal closure of such cases where we think that there could be abdominal compartment syndrome. So the only thing is that if we think that surgery is going to take time and we can control the infection by removing the source, by putting a drain, or by resecting the gangrenous segment and ligating it and putting it into the abdominal cavity. These are the conditions where we can perioperatively we can decide whether we have to go for damage control or we can go for definitive surgery.
All right. Thank you, sir. I think that is very well said. Aditya, do you mind taking the next question from Dr. Harshit Agarwal? He asks, how should one decide if to close the abdomen during the second surgery or not? So during definitive repair, which is often the second surgery, how should we decide whether or not to close the abdomen?
Yeah, thanks for the question. So I guess it is similar to the first question in that, are we keeping the abdomen open or closed? Do we decide to keep it open or closed? I guess one of the things is that, can you close the abdomen? Is it possible to close? For example, if there is a lot of abdominal wall edema and if there is a lot of bowel edema, then it is probably physically impossible to close. And then you might need to resort to techniques like Dr. Nayak said, bridging mesh or component separation or whatever it is. So in the second operation, if the source is controlled, or whatever the source of the sepsis was, whether it is, a perforation, diverticulitis, or whatever it is, if that is controlled and you've given a good wash and you're happy that, there is nothing else to do, then you have to close the abdomen. The times when you cannot close are, for example, physically it is impossible to close. There is ongoing sort of source of contamination, and that can be either some kind of an ongoing pancreatitis or ongoing necrosis due to that, which means that which will cause complications in the short term. If those situations are there, if the patient is still acidotic, if the patient is still on inotropes, then chances are that you still need some time for the physiology to catch up, and you might need to again resort to coming back for another relook.
Right. Thank you, Aditya. There is a comment from Dr. Amit that I think that the postgraduate should really look at. He talks about how these three principles of a bridge laparotomy, a source control, or surgery in the abdomen, and temporary abdominal closure are mutually exclusive and should be used only when indicated. I think that's an important thing, and I also agree with him that you have to understand which principle to be applied in which place. We move on to the next question from Joseph. Maybe I think Dr. Nayak, Professor Nayak, if you can take this.
Srijan, can I make a quick comment?
Yes, sir, please.
So, regarding the principles of damage control surgery and the temporary abdominal closure, I feel that most of the time when we talk about the principles, then we should stick to the principles of damage control surgery. And most of the time we feel that it is the resident who is operating in the middle of night and doing the surgeries. And his experience of deciding that, yes, I can close the abdomen. See, everybody can close the abdomen. Every abdomen can be closed. It's not a question of whether we can close the abdomen or not. Should we close the abdomen? That is the question. And a resident who is not very experienced and he is operating in the middle of night, and if we said that the temporary abdominal closure as a principle of the damage control surgery is not mandatory, or leave it to the chance, I think we should discuss this, and we should not give a message that yes, leave the you can close the abdomen if you feel like. There is no point taking the patient. See, why are you doing the damage control surgery? Because you are doing the damage control surgery to take the patient back to the theater after 48 hours or 72 hours. Once his physiology is okay, that time you can close the formal abdomen formally. So
Thank you.
my take on this, in the first surgery, if you are taking the patient with the intent to do damage control surgery, then it should be temporary abdominal closure, maybe skin only closure, or a mesh, or Bogota bag, or just a this IO bag or anything. But at the first surgery, it should be a temporary abdominal.
All right, that makes sense, because anyway you're going back in 24 to 48 hours. So why are you taking the additional risk? I think that's something that we have to let the postgraduate should understand. The Professor Naik, if I can ask you about Joseph's question, it's very important to understand this, especially as trauma surgeons. Our trauma patients are usually young, physiologically active. And Shantanu did mention during his presentation that there are additional factors to consider when to apply DCS principles in the non-trauma setting, because they can be elderly, they can have underlying malignancy like our first patient. The second patient had an unknown prothrombotic state. How does this affect surgical decision-making, recovery, and post-operative care? Professor Naik?
Well, before I attempt this, I think I do agree with Dr. Subodh that the principles have to be understood and applied. So somebody who falls into this category of damage control, probably then the first attempt we should never attempt to close. As he said, under anesthesia, any abdomen can be closed, but what will be the consequences? That is what we have to think through and then decide, okay, this patient benefits. If you can convince yourself that post-operative, this abdomen is going to lead to complications, better not to close. Take the chance and then come back in 24 hours. That will be much more easier on you as well as from the patient's recovery point of view. So, but the clarity about which patients will benefit with damage control is much more better understood in trauma settings as of today. And I'm sure in the days to come, things will be much clearer when you are talking about non-trauma patients undergoing damage control. That's because it is not only the patient itself, but so many parameters will come into the role play. For example, it is not only the pH has to be 7.2. It doesn't have to be that the patient has to be younger, old, lactate has to be more than 3. As of now, these are the principles with Becker et al. They have actually substantiated that septic shock with lactate more than 3, acidosis 7.2, age more than 70, male gender, pre-existing comorbidities more than 3. These are the groups probably will benefit. So older the patient, more likely that he'll take longer time to recover from the physiological damage or destruction. Whereas the younger patient is likely to bounce back much earlier. So I would tend to apply this damage control more easily in the elderly age group with septic focus than young patients. And of course, I personally feel that whenever there is generalized peritonitis, there is bowel ischemia, there are abscesses, and bowel integrity is questionable, and abdominal features of early abdominal compartment hypertension or compartment syndrome. These are definite indications that we should consider damage control. Is because if the patient survives this, probably he will survive the second surgery much better and recovery will be much quicker. And then avoid complications, post-op complications, both physiological as well as anatomical complications. Those are the things we should consider. Imagine joining a bowel which is very edematous and you do anastomosis. It is likely to leak. Therefore, the consequences will be bad outcome. So in those cases, why not take chance to improve the edema, decrease the bowel edema, improve the nutrition, circulation, microcirculation also improves. And then second stage, you do the anastomosis, it is likely to be successful. So keeping all this mind together, that how the patient is going to behave with whatever you do in the first index surgery, you have to decide damage control principle in those cases.
Okay, thank you, sir. I think the next question I'm going to ask is from Dr. Sushant to Aditya. When bridging mesh is an option, why should you consider component separation in the acute setting? I think he's talking about the second surgery or the definitive repair surgery. In those patients, should you consider component separation when a bridging mesh is available?
Yeah, so firstly, with a bridging mesh, you're essentially predisposing the patient to developing a hernia, ventral hernia, and then you'll have to sort it out later on as a third stage procedure or something like that. So ideally, I think component separation would be the first thing to do if we are definitively closing the abdomen. Again, the choice of component separation depends, but I would say that a transversus abdominis release or a posterior component separation would be the best thing to do in this case to get the maximum length. Secondly, I think I agree with all the panelists, with regard to the questions that were asked, I think depending on the main sort of questions are regarding the indications of the damage control process. I mean, if you're going to have a patient with a duodenal ulcer perforation, and you've repaired the perforation, you've controlled the sepsis, you've done a good wash, and a patient will have generalized peritonitis and you have sorted it out, you're not going to want to leave the abdomen open for something like that. But if you have a patient who has got some pathology which needs a resection of the bowel, patient is on high dose inotropes and quite acidotic, that is a kind of patient who would benefit from having some time to catch up in the ICU and then come back. If you have the patient who's got pancreatitis and definitely has got like compartment syndrome, and you have to leave the abdomen open for decompression while the physiology catches up and the pancreatitis settles a bit, that is a patient who will benefit from open abdomen. If you have a patient who's got like the second case, bowel ischemia, and you want to have a relook to better look at the bowel and then do an anastomosis later on, you have that opportunity with this. So that is also another sort of an indication. But whatever it is, I think in our mind, we should aim to close the abdomen as soon as possible and not wait. Yeah, that's about it.
Thank you, Aditya. The next question I'll take to Dr. Tiwari sir again. Dr. Avnish asks how abbreviated laparotomy is different in a DCS, acute care surgery DCS, opposed to a trauma patient.
In trauma patient, we usually try to stop the hemorrhage and contamination in DCS to break the cycle of the lethal triad. In acute non-trauma acute surgery, if there is bleeding, there is one source of bleeding. There is no multiple tissue bleeding in acute care surgery, we say as such. While in trauma patients, there may be more than one source of bleeding. Number one. Number two, the main thing in trauma patient is to stop the hemorrhage and to control the hemorrhagic shock. While in non-trauma acute care surgery patients, our main aim is to remove the source who is going to cause septic shock. So to control the sepsis, initially by resuscitation, by giving sepsis 3 bundle, and starting it within 1 hour and completing it within 3 hours, And then we, if not controlled, then we go for removal of the source of infection, go for laparotomy either, or we can go for, if there is a localized collection, we can go for percutaneous drainage also instead of going for laparotomy, and then to shift the patient in ICU. And once his general condition improves, then we can go for definitive laparotomy. So that is the basic difference, that in trauma DCS, we are aiming to break the cycle of this lethal triad, that is acidosis, hypothermia, and coagulopathy, and we are going to have to control the hemorrhage as well as contamination. While in acute care surgery, there could be only perforation peritonitis, for which we are going to perform damage control surgery. There could be pancreatic abscess or necrotizing pancreatitis, for which we are going to perform damage control surgery. Suppose if there is acute pancreatitis, necrotizing pancreatitis, then the best way is for damage control surgery is to put a drain, the ultrasound guided drain, into the lesser sac, let the abscess drain, let the patient improve in ICU for 48 to 72 hours, and then we can go for a pancreatic necrosectomy. So that there are clear-cut definitive indications. Now they are emerging in a acute care surgery in non-trauma patients for damage control, as we have discussed by other panelists also. And there are definitive indications for trauma patients for damage control surgery.
Thank you, sir. Thank you for that. And actually, thank you for bringing up the concept of a percutaneous drain during the emergency setting, because that ties in very nicely with the next question, which I'll actually take to Professor Nayak. Is there a place for damage control principles in laparoscopic or minimally invasive surgery? I would add, is there a place for drain
I think
placement?
we should be quick in now handling the questions. And
Yeah, I think thanks, Sujan. I'll tell you about my own personal experience to a visit to a rural hospital where patient had come after 3 or 4 days of peptic perforation. Patient was moribund, and the local surgeons actually put in 2 drains on 2 flanks under local anesthesia. And then after 48 hours, he took him for surgery. So that time, I did not agree with that principle and questioned him, and we had a big argument. And to my surprise, after 72 hours, when he went in, patient was physiologically much better. He did the closure and he walked out of the hospital on 7th day. So
Okay.
I think this principle was recognized by the clinicians much early. It is just that now more and more people are realizing the benefit of this. So whenever there is a collection or abscess, first thing is to drain it. How do you drain it? Depends on the resources and the expertise available. So percutaneous drainage is definitely will be helpful.
All right.
To bridge. Secondly, if whenever laparoscopy and all that probably being tried in some specialized centers, people those who are much more aggressive. But I think in the days to come, we might see more and more laparoscopy being utilized to assess whether the patient requires a formal laparotomy or a major resection or damage control surgery. So in assessment, probably laparoscopy may be come handy in the days to come.
Sure. Thank you, sir, for keeping it here for that succinct answer. Next question I'll take to Aditya. Dr. Ronak says most large bowel obstructional patients with distal growth with fecal perforations require damage control for massive contamination. He asks whether we should just decompress the whole large bowel or just do a tube colostomy drainage during the first stage or the phase 1 of the damage control.
What is the sorry? So the
He's
question is
asking,
basically, yeah.
decompress the whole large bowel, I'm assuming with an enterotomy, or just do a tube colostomy in the primary phase 1 surgery and then come out for an X-ray look in large bowel obstruction with perforation.
So if it's a perforation, then you would need to do a washout and remove the septic contamination anyway. And while you're doing that, you would probably be able to provide a stoma or some kind of fecal diversion. I think in general, I'll just give the example of a perforated diverticulitis, and where we do a Hartmann's procedure, or a similar thing for the situation that you mentioned. In those situations, again, you don't need to keep the abdomen open for these kind of things. You can just, you've cleared the sepsis, you provided a diversion, that's enough. I mean, you can close the abdomen there. Unless, of course, the patient is so physiologically unwell that it's better to do it at a later stage.
All right. Thank you.
I think,
I think time is up, sir. And we're
yeah,
done with questions. This is
yeah,
just a comment from Dr. Shashank explaining why he was talking about abdominal compartment syndrome. So thank
yeah,
you.
that's right. So thank you all the panelists, and I'm really grateful to all the panelists for sparing time and for a wonderful. I think this is one of the best tech rounds, and we had a very good discussion, unlike the previous this thing, because most of the time we are short of time, and because the case was presented well in time, so we could have a good discussion during this tech round. And I would like to announce that next month we will not have the tech round because we are having our annual conference, and I will request our Honorary Secretary, Dr. Sushma Sagar, to announce about the conference.
Good morning, everyone. And, I invite all of you, and all the ISTAC members should encourage all their residents, their co-faculties from various departments to come in large number and join at MGM Navi Mumbai for Trauma 2025. On 20th is the workshop day, and 21st and 22nd we have the conference. 22nd, in the second half, we have a special ATLS session where the 11th edition will be updated there. So all of you should come and join in large number. Thank you, Dr. Subodh. Please unmute.
Okay. Now, I want to use this opportunity to make a request to all the participants, the senior faculty members, the residents. I'm happy to announce that we have started an official journal of ISTAC by the name of Journal of Injury and Acute Care. So please encourage your resident to submit the papers, and I request all the faculty members to please be the reviewer of the journal. We badly need good reviewers for the journal. Please send your requests, and you can log in and make your account, and you can write to us that you want to be the reviewer of the journal. And I'm sure everybody's help will make this journal a success in times to come. And this is first journal related to trauma and acute care surgery from India or maybe Asia. So this is a sincere request to all of you. So with this, we can close the... Harshit, do you want to say anything, or we can just close for today's?
No, sir, nothing to be added. Just the request for more articles and for reviewers for the Journal of Injury and Acute Care, as you have already mentioned, sir. So this is only.
Thank you. This is actually your journal, everybody's journal. So
Yes.
please make it a success. Thank you very much. Thank you very much, and have a nice Sunday.
Thank you.
Thank you.